Good morning. So this is the chest pain lecture, and it's important to realize that this is nothing other than just an overview of chest pain. We will be doing individualized lectures for each of the disorders in the curriculum. The main objective here is to provide an overview of chest pain as a symptom and to provide some tools for the in-depth assessment of chest pain. Secondary objective is to provide some differential diagnoses for the symptom. This presentation needs to be watched together with the topic guide on chest pain. Have the prescribed references close by, as you will need to refer to them. This is not a standalone presentation and is designed to be used in conjunction with the EMC3 curriculum. When you get called out for a CVS emergency, the dispatch information is frequently that of chest pain. Chest pain is an important symptom in emergency care and one of the most common that you will encounter. It is also one of the most challenging, as might be no visible sign of a disorder. It's not like a broken leg or a stabbed chest or anaphylaxis where there's excessive swelling. One needs to rely on the description by the patient, which might be vague, it might be non-specific and definitely subjective. In this lecture we will take an overview of chest pain. Specific disorders will be dealt with on their own in accordance with the topic lists per the learner guide. During the management of pre-hospital chest pain, one finds oneself continuously weighing up odds, risks and benefits, and frequently with very little information to work with, and often with restricted treatment avenues. So it's pretty much like a balancing act. You're always weighing one thing against another when you're deciding what to do. South African EMS may have traits common to both the developing and the developed world, depending on which sector you work in, whether it be public or private. So literature from both developing and the developed world are relevant here. Overall, the significance of chest pain as a symptom is relevant to all EMS worldwide. The public is more educated about the symptom and consequently more aware of it. And they are also more aware of the services offered by EMS, so consequently they're using ambulances more to get to hospital for chest pain. In South Africa, cardiovascular disease is definitely on the rise. If we take a look at the global burden of disease study, you can see that globally, ischemic heart disease is one of the major causes of death worldwide. This study was commissioned by the World Bank. And if you look there, you'll see ischemic heart disease ranking right at the top at number 1. The picture's slightly different for sub-Saharan Africa. If we look at the top ranked diseases there, you can see a lot of it has got to do with communicable diseases. Although ischemic heart disease does make it onto the list at number 21. And it is definitely one of the top 10, 25 or top 25 causes of death in South Africa and is definitely gaining ground. Just another view of the percentage change in totally disability adjusted life years between 1990 and 2010, and you can see ischemic heart disease has seen almost a 40% increase since 1990. Internationally, between 17 and 29% of presentations to emergency services are for chest pain. Little or no data is available for South Africa specifically though. This includes data on patient presentations to emergency centres. An indication of the importance of the symptoms can be taken from a study completed in Cape Town, where over the period 2013 and 2014, at least 43% of all pain treated by Metro ALS was chest pain. If you need to pause the video now and just call up these two references, you'll see, if you read your topic guide, you will see where you could get them. We're going to need those to carry on with the with the presentation. It might be difficult to remember all the different causes of chest pain. Remember, it's not just cardiac chest pain that we're talking about. Sometimes it helps to create a picture, that is if you're a more visual type learner. Have a look at the picture of this chest of a cadaver cut through the transverse plane. If you consider all the structures of the chest, beginning from the skin on the outside and working your way inwards to the heart, you could probably come up with most of the causes of chest pain just by visualizing it. If we start on the outside, beginning with a chest wall, you could think of things like herpes zoster, which is shingles, costochondritis, rib fractures, muscle strain should immediately come to mind. Pulmonary causes might include embolism, pleuritis, or pneumothorax. And you can see we're moving through the chest wall into the lung over there. Visceral causes might include acute coronary syndromes, aortic dissections over there, mediastinitis, gastrointestinal disorders become important. If you look right over there, sits just behind the heart is the esophagus. So esophageal rupture, reflux, peptic ulcers, cholecystitis may all result in chest pain. This picture doesn't account for the disorders such as cocaine overdose or psychiatric causes of chest pain. These you have to learn. You'll see that in these two references there are some quite good tables which list extensive causes and very detailed causes of chest pain. Of course, in emergency services, simplification is king. So if you just remember this table, you should be able to get away with at least some safe practice. So the common causes would be acute coronary syndromes, musculoskeletal causes, anxiety is a significant, important cause of chest pain, esophageal rupture, as would be found after an episode of forceful vomiting, esophageal reflux. So remember to ask your patient if they've had their Gatsby today yet or not. Esophageal spasm, that's a very interesting one, which we will address later on when we do in the acute coronary syndromes lecture. And then some non-specific causes. The life-threatening causes of chest pain, of those which you really cannot miss, are acute coronary syndromes, pulmonary embolism, aortic dissection, and spontaneous pneumothorax if it should be tensioning. So how does one approach the chest pain case? Bearing in mind that you are dealing with a very challenging case in this symptom. Like most things in medicine, what you need to do is adopt a logical and systematic approach. If you don't know what you're doing, just take a step back, go back into your primary survey, take a deep breath, and start over again. Ask yourself the first question, and this should be obvious right from this off the bat. Is there trauma present or not? I mean, if there's trauma present, you might be looking at rib fractures, muscle strains, burns. It should be right at the top of the list. Of course, you need to differentiate the person who was driving or might have fallen off a ladder, who might have had a heart attack and then fallen off. Don't get tunnel vision by the trauma. You know, you still need to work out what caused the accident in the first place. Now, important to realize here is that I'm taking the point of departure that you've already completed your initial primary survey and you've begun to address these primary survey problems as you find them. This might include oxygenation, airway management, addressing ventilatory or circulatory concerns. You don't want to be caught jumping the gun and trying to calculate morphine doses and the patient is in cardiac arrest. So if there's no trauma associated with the chest pain, focus on the immediate life-threatening causes of chest pain and try either to include or exclude them. The ones to focus on here are ACS, aortic dissection, pulmonary embolism, cardiac tamponade, tension pneumothorax. So what you want to do are the standard ABCs, or CAB if the patient's already in cardiac arrest or about to go into cardiac arrest, or even if you find, let's say you come across a patient who has a life-threatening bleed. Of course, you're going to stop the bleed before you perhaps move on to the more advanced airway procedures. If the patient's hypoxic, apply oxygen. If they are in severe discomfort, position them appropriately. I can't stress how important it is to speak to the patient, calm them down as best you can, and include them in their healthcare. With chest pain specifically, the Hollywood effect is especially strong, as everybody would have seen the movie where someone dies of a heart attack. They may believe this is happening to them right now. So do not ignore. People are people. They are not objects. They are human beings, and they want to be spoken to. They want to be made to feel that everything is going to be all right. Once you've done that, manage their pain appropriately as best you can. Of course, you don't ever forget the glucose, and you're looking to include or exclude a life threat. So once your primary survey is complete and any corrective actions have been taken, move on to the history. And the patient history is probably one of your greatest weapons here. Context is important, such as the patient's age, their overall activity level, the events leading up to them calling you out, and those kinds of things. If you need memory joggers, the sample mnemonic may be useful. Evaluating the pain symptom itself is important. Memory aids for this might be the standard OPQRSTA or the Socrates mnemonics. The Socrates is very similar to the OPQRSTA. Stands for the site, the onset of the pain, the character of the pain. Is it crushing or burning? Does it radiate anywhere? Is what's associated with it? What kind of symptoms? The time periods involved. What exacerbates or relieves the pain, as well as the severity of the pain. During physical examination, pay attention to the vital signs, specifically the heart rate and the blood pressure. Pay attention to the patient's general appearance. You can read the two references for the further discussion on the vital signs. 12-lead ECGs are important, and you should try and obtain an ECG within 10 minutes of encountering the patient. They can be obtained in the field, and they can be interpreted by ECPs. It is possible to make decisions based on the ECG, though where we are perhaps lacking in South Africa is proper referral and consultation systems, including ECG telemetry. For now, taking a photograph with your cell phone and using a WhatsApp or a similar messaging service to transmit that photograph to someone who you are consulting with might be the best thing you've got. Risk stratification is a useful supplement to your assessment of chest pain, though be aware that the absence of risk factors, or obvious risk factors at least, does not mean that the person is not experiencing a significant or life-threatening disorder. Risk stratification scores may be useful, though some, such as the TIMI and the GRACE scores, can't really be used in a pre-hospital setting as they require special investigations. You can read up more on the Marburg rule in the PANDI reference, so we'll also deal with that when we handle ACS, and we'll look at the Wells criteria when we handle pulmonary embolism as well. So you've made your assessment. What do? Well, you manage the patient as you feel fit. You obviously direct your treatment at what is the cause of the chest pain. You make your transport decisions. Hopefully you're transporting to a place where the elevator works. All right. We're going to look at a few specific things around chest pain. Obviously, the pain characteristics are important. We'll look at that in a little bit. Auscultation of the patient's chest. Both you're looking at breathing, so you're looking for wheezes. You're looking for the start of pulmonary edema or chest pain. That is all as important. If you're really good with a stethoscope, you can be listening for cardiac murmurs, specifically mitral valve issues. You want to look at the associated symptoms that come with the chest pain. Is the patient sweating? Is he nauseous? Is there a tachycardia present, which might indicate sympathetic discharge? Is there a bradycardia present, which, if it's an ACS, might indicate damage to the conducting system? Is the patient lightheaded or dizzy? Does he have a decreased level of consciousness, which might point to decreased cerebral perfusion? And then, of course, as always, you want to look at the vital signs around or that you're experiencing, that you're finding in your patient. You can have a look at these two YouTube videos if you just want to go over cardiovascular assessment specifically, and if you also want to get an idea of what's going on regarding heart sounds. Okay, which disorders are chest pain generally associated with? Well, you'll see there's a very long list of disorders which can cause chest pain, but we're going to just speak a bit about these few. So we're going to look at ACS, myocardial infarction. That would be both the STEMI and the NSTEMI, together with unstable angina. As already mentioned, the most important disorder to look for is acute coronary syndrome, and this should be actively sought and either excluded or included in your assessment. Classically described chest pain is retrosternal in the left anterior chest with a crushing, tight or squeezing feeling, commonly described as pressure. It might be brought on by exertion and relieved by rest. There may be associated symptoms such as dyspnea, diaphoresis, nausea, pain radiating to the left shoulder, the jaw, the arm, the hand. Some patients might experience pain very differently. I'm referring to groups such as diabetics, elderly, and people with psychiatric disease or altered mental status. Pain is not an absolute requirement for AMI, and one should be aware of AMI in the absence of pain in certain populations. Chest pain, though, does speed up the patient's journey through the healthcare system, especially in the emergency department. And typically people without chest pain have a longer time to treatment than people with chest pain, even if those without chest pain are indeed having a significant event. The onset of symptoms attributed to cardiac disease may be sudden or gradual. Traditionally, angina pain lasts for 2 to 10 minutes. Unstable angina pain lasts for up to half an hour, and AMI pain often lasts longer than 30 minutes. Dyspnea at rest or with exertion, nausea, lightheadedness, generalized weakness, acute changes in mental status, sweating or shoulder or arm or jaw discomfort may be your only presenting symptoms for ACS for some patients. We move on to pulmonary embolism. The pain of pulmonary embolism may often be of sudden onset. It's a pleuritic chest pain associated with dyspnea, tachypnea, tachycardia, or hypoxemia. Pleuritic chest pain is typically pain that is very sharp in nature. Risk factors include prolonged immobilization, cancer, recent surgery or trauma, procoagulant syndromes, pregnancy or hormonal therapies where they might be receiving exogenous estrogen, or patients who have a previous thromboembolic disease. Aortic dissection is a potentially catastrophic cause of chest pain. It's typically of sudden onset. It's maximally severe. At onset, a tearing pain radiating to the intrascapular area of the back. Secondary symptoms might result from the arterial branch occlusions. They might include ischemic stroke, AMI, limb ischemia. Remember, what's happening here is there's a dissection through the different layers of the aorta, and all the arteries branching off from the aorta are being occluded as this column of blood cleaves apart or splits the layers, and then they start to occlude the bits of the or the arteries that are branching off the aorta. This is where you want to compare two different pulses on either side of the hand. or not. Risk factors include male sex, age older than 50, uncontrolled hypertension, connective tissue disorders, cocaine use, bicuspid valve or aortic valve replacements in pregnancies. We're also looking at the Marfan syndrome. The physical exam findings may include unilateral pulse deficits or focal neurological deficits, which I've already described earlier. Esophageal rupture is again often presents with sudden onset. It's a sharp substernal chest pain that follows an episode of forceful vomiting. Patients are usually ill appearing with tachycardia, fever, dyspnea, diaphoresis. Physical exam might reveal crepitus in the neck or the chest from subcutaneous emphysema. Spontaneous pneumothorax once again has a sudden onset, sharp pleuritic type chest pain with dyspnea. These are classically occur in tall, slender males, and risk factors include smoking, COPD, asthma. Physical exam findings are inconsistent. Auscultation might reveal decreased breath sounds on the affected side. A very important one, and one that we're going to address later on again when we look at the ECGs, is pain from acute pericarditis, which is typically sharp, it's severe, it's constant. It's a retrosternal pain that radiates to the back, the neck, or the jaw. The pain, the classic description of it is the pain is worsened by lying supine and is relieved by sitting up and sitting forward. As the ECG might show PR segment depressions, diffuse ST elevations, or T-wave inversions. Then we look at all the musculoskeletal causes of chest pain, typically due to irritation or inflammation of the structures in the chest wall. Possible causes include the costochondritis, intercostal muscle strain from, say, coughing, pectoralis muscle strain in the setting of recent physical exertion. Patients often complain of a sharp pain that is worsened with movement of the chest wall and palpation. They need to apply some judgment here. Obviously, if someone says that they have a pain or around an area of the chest, or you are palpating the chest and you push hard and they say ouch, even a person with a normal healthy chest, if you push hard enough, you're going to elicit pain. So just exercise some judgment there during your palpation. Chest wall tenderness might also be present in some patients with ACS or other significant D processes. A clear musculoskeletal etiology with reproducible pain in a patient without other symptoms or risk factors supports a diagnosis of a musculoskeletal cause. If we have a look at the gastrointestinal causes, we're looking at esophageal reflux, dyspepsia syndromes, and things like esophageal motility disorders that can't really be reliably differentiated from ACS by history and exam alone. Symptoms in GIT disorders might range from a gnawing or burning pain in the lower chest, a boring pain in the epigastric region, typically is found in peptic ulcer disease. Esophageal spasm is often associated with reflux disease. It's characterized by a sudden onset of dull or tight substernal chest pain. And here's a catch here, is that esophageal spasm is typically relieved by nitroglycerin, which might lead you to mistakenly say that, well, we've now relieved a cardiac type chest pain over here. So, as I said, we're going to go over, explore the causes of chest pain in the individual disorders again. Chest pain is not an easy disease to treat. It's one typically associated with a lot of urgency, a lot of panic in a lot of people. You need to be aware of false positives. And the thing is, frequently lower risk populations may produce higher rates of false positives as well. So you really need to keep your thinking cap on when addressing these types of patients. Well, there we go. Thank you very much for listening. If you've got any questions, you can speak to me in class or email.